The final presentation, as I said, will tackle a common problem we all face during our practice, which is lymphedema of the arm. I have the pleasure to introduce Professor Alphonse Tajian. The title is Lymphedema, a new approach to an old problem.
Thank you. I will try to move quickly. I know everybody is probably hungry, waiting for lunch. I want you to imagine this patient who has 54% mole volume in the right arm, how her life looks like. And she's a survivor from breast cancer maybe 10 or 15 years later. So she was probably cured, and that's what she is left with. Impact on her life, mentally, psychologically. And everywhere she goes, people ask her, why do you have a large arm? How can she fit her clothes? That's the impact of lymphedema. Even 31% is still too big. Even 19% difference, I think, is still too big and very difficult to treat. 9% is a little bit better. And what about if we can detect lymphedema at a very early stage? And that's what I'm going to talk about. We need to change the way how we think about lymphedema. What we are doing today, or the way how we think about lymphedema today, is based on an impairment model, which means that when I see it, I send the patient to physical therapy and they deal with her. And when you see lymphedema, it's already too late. Because even if you see it very early with your eye, it's already 10% and becomes very difficult to treat, and it becomes a chronic problem. The people who deal with lymphedema are the physical therapists, so they are at the other end. And usually they deal with the patient after the problem happens. There is no definition for lymphedema, and I will go over this. There is no optimal method of measurement of lymphedema, and I will go over this. And there is no level 1 evidence or phase 3 randomized trial on how should we treat or what policy should we have. What I'm trying to do is to change this model into a screening-based model, and this model was successful in mammography. When we screened for breast cancer, the rate of ductal carcinoma in situ went up from 2 or 3% of patients who present with breast cancer into 25 and 30%. And here, mortality from breast cancer has decreased, and the cure rate has increased. We need to apply this model into lymphedema, screen for it, and then you detect it very early. Maybe you might be successful in preventing progression. We need to clean the house. We need to define what is lymphedema. We need to find out what is the optimal method for measurements. We need to determine a threshold where we intervene. Should we intervene at 10%, at 15%, at 20%? We need to do that. We need to generate level 1 evidence, a phase 3 trial. And we need to be aware of the cost. There is no doubt that lymphedema can cause a negative impact on the quality of life of women. We don't need data for that, just we need a common sense. There is no doubt that it causes a negative impact on body image, and there is plenty of information about that, and it also decreases the upper extremity function. Patients cannot move her shoulder freely. It is a devastating disease that is under-researched, and people are just focused on treatment, but the quality of life of these women is as important. There is also some misunderstanding in the literature. A lot of women are afraid to use the right arm or her arm when she has a mastectomy or a lumpectomy or a treated side, in her treated side. And this is wrong, because they think when they use their arm frequently that it might increase the risk of lymphedema, but data shows the opposite. There is data from trials which demonstrate that exercise is well tolerated and does not increase lymphedema. There is data which supports that exercise, even weight lifting, if it is well controlled and progressive, it actually improves lymphedema. So there is some misunderstanding even among healthcare providers about lymphedema. So let's go to the incidence. The incidence is around 20 to 30% after lymph node dissection. Now, with advancement in surgical techniques and the increased use of sentinel node, this went down into 5 to 9% of clinical lymphedema. And clinical lymphedema means you see it, is around 10%. Now, if there is any place where we should discuss lymphedema, Egypt comes on the top of this list, because my understanding is that the great majority of women still undergo lymph node dissection, and sentinel node mapping is not frequently used. And also, women here usually present with more advanced disease, so most of them will have lymph node dissection anyhow. So we need to be mindful of this problem. Now, subclinical lymphedema, which means there is a difference in volume, but it's not seen by the eye, it's just measured. And this risk is quite high with the lymph node dissection, and with the sentinel node is around 15 to 20%. Now, the classic risk factors to develop lymphedema is lymph node dissection. It's actually wound infection. Anytime you have a cellulitis, that's an increased risk for lymphedema. When we treat the axilla with radiation, that's an increased risk with lymphedema. And we found also that a high body mass index is a potential risk for lymphedema. Now, potential risk factors, there will be number of nodes removed and also number of positive lymph nodes. Now, what is the definition of lymphedema as described in the literature? Often it is reported as more than 2 centimeter difference in circumference using a very simple tape. Now, I will show you how reliable is this method. Some people would say lymphedema should be at least 20% in difference in volume of the arm. So it's not circumference anymore, it's volume of the arm. And others will define it as 10%. And some people from the NIH in Bethesda said, we have to go all the way in the other side, and we'll consider lymphedema as only 3%. And some people will tell you, let's look at it by the absolute number or difference in milliliter, 150 or 250. And this tells you very clearly that there is no universal definition of lymphedema. And this is a general review of all publications which looked at lymphedema. And this is actually a recent one. And it shows you how these papers define lymphedema. Still, the great majority of these papers will define lymphedema by difference in 2 centimeter, difference in circumference between both arms by 2 centimeters. Those are 20 papers, and there are also other papers which will define it as a difference in volume using the water displacement method, and I will show it to you. And those are 13 or 15 papers. So until today, the great majority of people will define lymphedema as difference in circumference by 2 centimeters. I will tell you why this method is not good. So let's raise some questions and try to answer from the data we know. What is the optimal method to quantify changes in arm volume, or how should we measure lymphedema? So there are 4 methods described in the literature. The tape measurement, which is very popular. There's a water displacement. There's a method which is called bioimpedance, which is mostly used in Australia and trying to find a market in the US. And there is a method called pyrometer. So let's take the tape measurements. Usually, an oncologist, when they see the patient, will measure the circumference of the arm in 2 or 3 points. That's all. So I will tell you, measure from the olecranon 10 centimeter below and take a circumference here, and 10 centimeter above and take a circumference here, and here we are. Now, if you send the patient to a physical therapist, they are more thorough than the oncologist because maybe the oncologist don't have enough time, and they will measure the circumference every 4 centimeters. And actually, by putting these measurements in a software or online, they can generate the volume of the arm. So you will have a better, more accurate assessment of the volume of the arm. I apologize about this. This was not in my original slide. But anyhow, so I want you to imagine the reliability. Sometimes you are a little bit loose with the tape. Other time you are tight a little. So reliability of the 2 centimeter circumference might not be high. The other method is what they call water displacement. So the patient put her arm all the way down and there is water here. And when the water is displaced from the baseline or the contralateral side, it is displaced with a number of milliliter. So this method is messy, and you need to change this container between each patient. Is not very also reliable. Now, looking at the definition of lymphedema, when people will tell you it's 2 centimeter circumference or it's 200 milliliter difference, now, I want you to think with me. If you have a very tiny arm like this one, and you just increase by 180 milliliter, now the definition is 200. So 180 milliliter is not officially lymphedema. This is a difference of 15%. And again, this is not reported in a trial or in any study as lymphedema. Now you go to the other side. If you have a very large arm and this arm circumference is increased by 2 centimeters or is increased by 220 milliliter, this is officially lymphedema, and the difference is only 3.5%. So you would treat this patient who has 3.5% difference, and you would not treat this patient who has 15%. So if you use an absolute difference without taking in consideration how was the arm before, it will not make any sense. And yet, that's the way how lymphedema is defined in the literature today, and that's the method used in big randomized trials like the Z11 trial or like the NSABP B32. When they do a quality of life parallel study, they use 2 centimeters and they use 200 ml. Now you do the same thing. If this patient has a very large arm, and just if she pushes her arm a little bit more by 0.5 centimeter because of the size of her arm, the displacement might be very significant. So this method is not reliable. Now the third method is the bioimpedance. It's a sort of like, it's a device which looks like a little EKG, and you put the electrodes in the arm and the leg, and there is an electric current, and they measure how the electric current passes, and it has an inversal relationship with the presence of water under the skin. And they have a calculation and stuff like that. It's relatively new. You should have an empty bladder. You should not have exercised or drink any caffeine or coffee 2 hours prior. It has some conditions, and it's being used. I'm not sure about how reliable it is. We are conducting a trial in my department assessing how this method is. But the method I'm using at this point is something called pyrometer, and it is actually an infrared volumeter. And what happens is that the arm is put like that, and this frame moves back and forth. It takes 2 minutes. And right away on your screen, you will have the volume of your arm with a lot of measurements. Actually, it's measuring the circumference every half a centimeter. And it tells you right away the volume of your arm. Your arm is 2,000 milliliter or 2,500 milliliter. You do the right side and the left side as a control, or the untreated side as a control, and it shows right away what is the difference in volume, in percentage-wise. And it also shows you when you treat in a longitudinal way with the time, what is the volume of your arm. Now question, how do we calculate the lymphedema volume? Now, something we realized is that if you don't have a measurement before treatment, your measurements after that will not be reliable, because 20% of women without any treatment will have one arm bigger than the other. And some of them can have up to 10% different in volume. So if you don't have this information before you measure the arm after treatment, your measurement will be basically wrong and unreliable. So we measured maybe 500 or 600 patients, and we looked at their baseline, and we found this Bell distribution. But you have people at this side or that side, they have really up till 10% difference. So very important to measure patients before they start treatment. And that's why I need from oncologists to really look at this problem, because the surgeon sees the patient before any surgery, before any treatment, and the surgeon might end up to be the person who needs to get these measurements at baseline. Now, how do we calculate lymphedema? We've done a study over 700 patients with almost 10,000 different measurements, and we gave this problem to a mathematician and to put or to design an equation. And he ended up by putting an equation. It's called relative volume change, which is very simple. It takes in consideration the affected arm and the unaffected arm, and 1 means baseline and 2 means the measurements du jour. So basically, the assessment of lymphedema here takes in control 2 things: the baseline before any treatment and the opposite arm, which has not been affected. Question, what is the natural time course of lymphedema? So in the literature today, most studies will define lymphedema by 1 snapshot of measurements. And I put some of this literature. So the majority of studies which report the incidence of lymphedema, they are based on a single measurement. There are some recent papers even reported 5 years later with just like measurements in the beginning and measurements 5 years. There is no natural history in between. Now, we have shown that there is 2 or 3 types of lymphedema, what we call a persistent lymphedema and a transient lymphedema. It's actually, there's a large number of patients, and maybe surgeons might have observed that, who will have some slight swelling of their arm immediately after surgery and can stay for 1 or 2 months, and then it disappears after that. And we have to be careful with this, because you need to inform the patient about that, because patients are afraid of lymphedema. Patients who read about it, they are afraid of it. Transient lymphedema, we defined it as lymphedema which stays for less than 4 months, and there is actually another type of lymphedema or swelling which is recurrent, like waxing and waning. It comes and it goes, and it comes and it goes. We defined lymphedema into mild and moderate. Moderate here, the 10% is when you see it with your eyes. The 5 to 10%, you might not see it in your eyes. Maybe you could see the 9% a little, but when it comes to the 5%, it's only detected with measurements. Now, we studied 578 patients with a median follow-up of 24 months, and we found that transient lymphedema occurs in almost 56% of these patients, and it happens within the first 6 weeks. The persistent one occurred in 44% of the patient. It happens later. And sometimes women who develop the transient lymphedema, so it comes and then disappears for several months, and then it shows up again at the end. So we found that women who develop the transient, they are predisposed to develop the permanent one. And 38% of all lymphedema cases presented within 3 months, 60% were transient and 40% permanent. So the swelling which comes early on is mostly transient. Lymph node dissection, lymph node radiation, BMI more than 25, those are the risk factors. And if you have 2 or the 3 of them, your risk of lymphedema is quite high. What is the appropriate threshold to initiate intervention? When should we intervene? Should we wait until we see it? Should we wait until 10%, or should we intervene a little bit earlier before it starts to bother women? Now, in the literature, people will tell you intervene at 10% or 20 or 200 ml or 250, or when you have more than 2 centimeters. So again, it's symptoms-based model. When the patient develops the problem, let's deal with it. And here, we think it's a little bit too late, or it is very difficult to treat. Now, the NIH ran a phase 2 trial. They actually treated women at only 3%. They used a pyrometer, the same machine we use. And as soon as patients started with just a slight difference, by 3%, they gave them sleeves for, I believe, 12 weeks, and most of them, the swelling went away. And this was a very sort of like successful treatment. And so they call this a screening-based model. Intervene before you see it, intervene before it causes symptoms. We had some issue with this study because it's not randomized. And also, we initiated a study at Mass General to verify whether the 3% is the right time to intervene or not. And we screened every woman who comes to be treated for breast cancer at Mass General. It's part of our basic assessment of patients. Like anywhere, we look at the blood pressure, we look at the heart rate, and we look at the volume of the arm. We put it in her file. Any woman who opens the door at Mass General for treatment for breast cancer have her arm measured. And of course, after treatment, after chemo, after radiation, and every time she comes for follow-up twice a year, we measure her. And we had a natural history study, like let's observe, let's measure and observe, all the way up till 10%. How do they do? When do they develop swelling? When do they go back and forth? To try to understand what lymphedema is. And we divided patients into women who had 3% or less, 3 to 5%, 5 to 10%, and more than 10%. And this is some of the examples. 3 to 5%, you just can't see it. 5 to 10%, you might see a little or you might not. It depends if it is 5 or 6 or 9 or 10. And more than 10%, you see the lymphedema. And of course, this large arm is 54%. So we found out that women who develop 3 to 5%, the majority of them recover without any intervention. So we think that this NIH study, they over-treated a lot of women. If they have just observed these women who develop 3%, they will recover on their own. The 5 to 10%, half of them recovered, and the other half stayed or progressed. And the 10%, the majority progressed, which suggests the following. The 10% should be treated for sure, they progress. The 5 to 10%, we don't know whether we should treat or not. Maybe we should wait until they progress and treat, or maybe we should treat. And that's why we initiated a phase 3 randomized trial to take this 5 to 10% and randomize between treatment and no treatment. The treatment is ironically very simple. It's just to put a sleeve for 12 weeks. Maybe with a very simple treatment like that, you can prevent progression of lymphedema. Question: how can we correlate patient-reported lymphedema and quantitative volume measurements? Which means, you might ask the question, how do you know that this 5% or 6% annoys the patient? The patient is happy. Why do you have to intervene? So we needed to collect data and correlate the level of symptoms with the level of swelling. And we are doing this, and we collect this data with 3 surveys together: symptoms, function, quality of life, and we do it electronically. Every time the patient comes for arm measurements, she fills out this questionnaire. So we know the volume of the arm is the same day she filled up this survey. Some of the questions are: have you noticed a change in the way your rings fit? Quality of life. I am able to enjoy life. I get emotional support from my family, etc., etc. It's a 12-minute survey. What is the appropriate treatment for low-volume lymphedema? And the hypothesis we are raising: will early intervention prevent progression to a larger edema? If we detect it early, can we prevent it? So we initiated clinical trial to generate level 1 evidence, and it's 2 parts. This trial is still in progress, so I have no data with the results. It takes patients once they cross 5%, so we don't treat at 3%, 5 to 10%. Now, in order to avoid over-treating transient lymphedema, we have to confirm the measurement 6 weeks later. So we measure today, it's 7%, for instance. We measure again 6 weeks later. If the patient still remains in the 5 to 10%, we do the randomization between observation or sleeve for 12 weeks. It's as simple as that. Now, what if the patient moves into a higher category of lymphedema, the 10 to 20%? We actually randomize patients between a simple sleeve for 12 weeks versus sleeve and bandage 5 to 7 nights a week. Why did we do that? Because this is the standard of treatment. The patient needs to bandage, to massage her arm. Now, women will do it maybe 1 week or 2, and they will stop doing that because they will not be compliant for 12 weeks. Every night they wrap their arm. So we know that they are not compliant, but we don't know whether it's necessary or not. That's why we are putting this in the randomization. The primary goal of this study is to discern an appropriate threshold for lymphedema intervention, to see the efficacy of compression and the night bandaging, to evaluate the significance of low-volume edema, and to correlate with the symptoms. So far, we have screened more than 3,000 women, and we have 1,700 with at least 3 measurements. The median number of measurements is 5, and we have a median follow-up of 2 years. The people who participated in the screening protocol is around 1,000 patients, and we have in the intervention 18 patients.